Olalua Ezekiel Dada. I'm a second-year medical student from the University of Ibadan. I'm a research fellow at the Association of Future African Neurosurgeons. I welcome you all to today's JODA Club webinar presentation. Chibukem, can you go ahead to present yourself?
Thank you very much, Ezekiel. Good evening, everyone. I'm Dr. Chibuike in Lagos, Nigeria, a research fellow at AFAN.
Thank you. Welcome, Chibukem. Bejo, can you go ahead to present yourself?
Thank you very much, Ezekiel. I'm Takutin Dokmo Bejo, CTA medical student at the University of Boye in Cameroon, and a research fellow at the Association of Future African Neurosurgeons. Glad to be here.
Yeah, thank you. You're welcome. Darwin, can you present yourself? Okay, he said his network is actually bad. Shituluka, can you present yourself?
Good evening, everyone. My name is Mr. Kanashituruka. I'm a final year student from Copperbelt University, Zambia, and I'm glad to be here.
Thank you. You're welcome. Chidebere, please present yourself.
Hi, everyone. Good evening. I'm Chidebere Bay, and I'm the creative director of the Association of Future African Neurosurgeons, and I'm also a medical illustrator. It's good to be here today.
Thank you. You're welcome. Defo, can you please present yourself?
Good evening, everyone. I'm Genolin Defo, FIDA medical student, University of Boya, Cameroon. I'm a member of communication team of Future African Neurosurgeon. Thank you.
Thank you, Defo. Asen, can you please unmute and present yourself?
Hello, everyone. My name is Arsen Daniel from the Democratic Republic of Congo. I'm a medical doctor, and it is a great pleasure to be a part of this.
Thank you. You're welcome. Becklin, please unmute and present yourself. Oh, I think probably had some glitches with this network. Okay, Micah is going to go ahead to present himself and go ahead with this presentation. Thank you. Micah, you have the floor.
Thank you, Ezekiel. How is everyone doing? I hope everyone's having a nice weekend so far. So my name is Michael BAMIMORE. I'm currently a fifth-year medical student at the Philadelphia College of Osteopathic Medicine. I'm currently doing a research here at the Mayo Clinic here in Jacksonville, Florida, and we'll be applying into neurosurgery residency later this year. So I'm gonna quickly share my screen with the paper we'll be talking about today. So essentially the goal of today will be for us to mostly discuss the literature, the importance of the literature that we see in front of us, not just the science that has been discussed here, but also trying to dissect the methodology of the research, what goes into coming up with the introduction, the abstract, results and discussion. So I will be, calling on people to kind of help answer some questions as we, further dissect into this literature. And my hope is that everyone has, to some extent, read the paper and have some overview of what this paper is talking about. So, just a general overview. This is a paper called The New Classification of Complications in Neurosurgery, a relatively straightforward and simple paper that we can get started on. So I guess my first question, especially just looking at the paper, would be what we all think about the title. Do we think the title is informative? Do we think it's relevant? Do we think also overall, do we think the study, from what you've read, do we think it's novel or relevant? So I'm gonna give the floor to, let's see. So I actually can't see the people that are on here. Okay, so let's see. Let's call on Berjo, right? Am I correct?
Yeah, thank you. Okay.
Mm-hmm.
So for the title, like comparing the title to the abstract, I would have loved to put the title in a different way. Like for example, at level of the when we talk about the new classification, I would have loved to instead put a new grading system.
Yes.
A new grading system, and at the level of the complications, I would have loved to instead add post-op complications. And at the end now, I'll precise a study, a single center study.
Yes. I feel like, yeah. Do you have more to say? Sorry.
Yeah. Just that for the title.
I think that's actually a brilliant analysis of what you just said, because reading the title, it can seem like it's a little bit more general, and having something that's more specific, can give you an idea of what the paper is all about. Just before I go into talking about the full picture of what I thought, is there anyone else who has any input into what they think about the title of the paper? Okay. So, just like Berjo said, it would be better if the title was more specific. And in this situation, this is a study that was done at a single center. This is a single center study. Adding a single center study would help you to at least have some knowledge of what to expect in terms of the results, how generalizable this result could potentially be. So, essentially, I felt that the title was general and it could be more specific. So I thought Berjo did a good job working on that. Now, my question is, when we look at this abstract, or when we look at the way the abstract describes the study, do we think this study is novel? And do we also think this study is relevant? I'm going to call on Shidi Bere for this one. Okay. How about Chibukem? Dr. Chibukem.
Oh, hi. I can't really speak to the relevance of the study, although I'd like to say that from their conclusions, kind of like stating that the main advantages of this classification are to be able to compare surgical results among different centers. And I think that is kind of like important. Like it's kind of like important to be able to compare your results and have like a uniform means of comparison, so to speak. So in that regard, I think there's some relevance there. Well, about its being novel, I'm not sure, because I don't think I've read any of such works before.
Yeah, I agree with your analysis. In terms of being relevant, I think the study is relevant in the sense that it's helping to unify the definition of an outcome, trying to standardize what an outcome should be in neurosurgery, in brain surgery or spine surgery. However, when it comes to novelty, I mean, even in the study itself, it kind of highlighted 4 different studies that have already been done in the past, presenting or proposing almost the same classifications that the study is also proposing. So I wouldn't necessarily say that the study is novel. However, I could see the relevance in it in the sense that it's trying to create a unification of classification. So, one of the major problems that the study kind of posed was that there's a lack of standardization in terms of the way that neurosurgeons classify their complications, and that can lead to subjectification of your negative outcomes. So I agree with you. Thank you, Dr. Chibukem.
Hello.
Yeah, hello.
Yeah, I don't know. I have a little suggestion. Yeah, I don't know if it's better that maybe we just discuss on the abstract or finish with the abstract before we go now to the various parts of the main text. I don't know if you guys before elaborating on the introduction, the whole study. I think it would be good that we do the abstract before we go now to the main text.
Okay, yeah, that's fine. Sure. So, I mean, I guess a good thing to ask in this situation is, what do we think about the aim of the abstract? Do we think that the aim of the abstract, do we think it's clear in this situation? So if you want to take this question, I'll be happy to oblige.
Okay. Can I go on this?
Yes, yes.
Okay. I will start with the aim. Because when you compare the aim, the title and the aim of this study, because this study talks about they want to grade neurosurgical and spinal postoperative complications. I thought that it would have just been very simple just to say neurosurgical procedures and just end there, because if you are talking about the spinal procedures, for me, I have the impression that we are like talking about the neurosurgical and orthopedic procedures. I don't know. So I was thinking that like aim will just focus post-op, like we just say directly neurosurgical complications, post-op neurosurgical complications, and we end there. Not need mentioning again spinal, because I'll assume that if you are talking about neurosurgical complications, there's a vast majority. It can include spine surgery, it can include brain surgery, and even nerves. So that is my own opinion.
Yeah, I understand. I agree with what you said. But what I was thinking when I read that part was that, there's the two different specialties that kind of run a certain half of neurosurgery, which is spine surgery, right? So, spine surgeons are made up of neurosurgeons and also orthopedic spine surgeons. So I'm guessing in this situation, maybe what they're thinking is like trying to include both halves of the equation, because if you just say neurosurgical postoperative complications, you're only, I guess, condemning this study to only be relevant to neurosurgeons and not particularly orthopedic spine surgeons that also do spine procedures, who could also benefit from adopting this potential grading system. I don't know if that makes sense.
Okay. Yeah. Okay. Yeah. Thank you. I also want to comment a little bit on the method. I love the method.
Go ahead.
Yeah. At the method section, I'm not really satisfied with the grading system used there. Yeah, it's nice, but I think it would have been better, because they talk about grading, giving for a 4-grade scale based on the need for treatment. That is it. On the objectives, and I talk about based on the need for treatment. But now, when you see the grading, you see that they consider at the same time the need for treatment and which type of treatment. They consider the mortality, the mortality, if it's life-threatening or not, and they also consider the setting at which both patients have been managed. So I think that they could have had, like, say, okay, this grading is also consider the mortality and the setting at which, like that is where the patient has been managed. So that's one part of my comment on the method. And also the grading, when you see from grade 1 to grade 2, the grading, in my own opinion, is not really uniform, because when you leave from grade 1, I don't know, it's not best that we discuss much these details better later on, like to go deep into the methods now. I don't know.
I mean, yeah, we can save that for whenever we're in the method section. So just to kind of do like a brief overview of just what you thought about the methods in the abstract section, and how you think it overall gives you a good impression of what the paper could be, right?
Okay.
Yeah. But I think you did a pretty good job, kind of interpreting, what you found. And in terms of the way that the grading systems were laid out in the methods section and getting me ready to read the paper, I thought it did a pretty good job highlighting what the different grading methods particularly entail. The only problem is that, in a method session like this, where you have a cohort of patients, right? especially in the abstract section. They don't have anything that kind of talks about what inclusion criteria they use to choose their patients that were included in the method that would use in the methods. That's like the one thing that I could highlight in the method section for the abstract. I don't know if you agree.
Yeah, I do, because you see, they just mentioned patients. They did not precise what patients.
Exactly.
Just mention patients.
Yeah. Exactly. Yeah. So we can. Yeah. Sorry. Go ahead.
Yeah, I agree with that, because I'm kind of like trying to look at the abstract and thinking to myself how I would have done such a study, and then it was kind of like difficult to follow because a lot of things are missing in methods abstract. Yeah.
Absolutely.
So I agree.
Yeah, and let's call on Musakanya. Am I saying that right? How about Dr. Defoe? Are you there? Okay. I'll call on Ezekiel for this one. What are your impressions of the results in the conclusion section in the abstract, in terms of getting you ready to even go into the paper? What did you think?
To me, I think the results section actually, probably the analysis is more than that, but I think the result could have been more detailed than this. I know this is an abstract, but I doubt if this is giving us even a brief overview of what they actually got. Then the conclusion isn't bad. I think the conclusion is okay.
Hello.
Yeah.
Hello. Yeah, I think for me, it's true what Ezekiel said about, like, it's short, but there's this issue of what limits in the abstract. And for my own interpretation of the results, the authors here are just simply trying to tell you that they were able to classify all the patients that had complications in those various grades, those various grading systems. There's my interpretation of the results. Like, for me, it's like they are testing like they propose a system in the method, and they make sure that they went into the project and see, can we actually make sure that everyone falls in each of these grades, because that is and that's what will make the grading system actually relevant, if actually all the patients fall at least in any of those grades.
Yeah, I agree with what you said. And I think, like, even in the results section, one of the things that I noticed is, like, they should be able to highlight what, I mean, because they should have been able to break down the patient characteristics, one, and breaking down the characteristics of the patient should help you to highlight which factors predisposes certain patients to being in whatever grade that they're going to be in, right? So, like, are patients who end up in grade 4 or grade 3 more likely to be older patients, more likely to have bad
comorbidities?
Yeah, exactly. Comorbidities, exactly. So I don't know if you agree with that, if you guys agree with that or not.
Yeah.
So all right. So let's in the essence of time, let's move into the introduction section. So my question with this is actually pretty straightforward. So, based off of what we've read from the introduction, do we think the research question that they're asking, do we think is it justified given what the background data that they presented on their study? Is it justified based on the background data that they presented?
Okay, let me just take it. For me, the main thing that I saw in terms of just justifying this research is that they talked about that there are various studies who talk about multiple grading system, but in practice there's usually kind of confusion. Like, each person wants to use this method, this one wants to use this method. So these authors here try to look for, they're looking for a uniform way of grading the post-op complications. So that's for me the justification for this topic.
Yeah, I agree with that too. And when you read the background data, they talk about a lot of previously published prepositions propositions on, different classification systems, like the one by Clavian here, where, he proposed a classification for general surgery, which was then being used for 6 years at their institution. And, there are other studies that were also proposed by other people, which kind of gives us a clue that this has definitely been done before. However, the question that they were trying to answer is there a way that we can standardize this grading system where neurosurgeons can actually be able to? I think one of the most important things they mentioned was, right at the moment, you can't compare, data from complications data from a particular hospital with different time periods, because there's no standardizations of what negative outcome is. And I felt like they did a pretty good job in highlighting the background data. And I believe that in a way justifies the questions that they're trying to answer, because they're not only just trying to just propose a new classification. I think they're also trying to find a way to unify where everyone can actually fall under one classification system. Okay. Does anyone have anything else to add on that end? Techno Spark, you have your microphone on. Do you want to say something?
No.
Okay.
I'm just listening.
Okay. Do we think in the introduction section, as they're introducing this topic, do we think the question that they're asking is clearly stated? Let's see what you think, Dr. Chibukem.
Yeah. I think the question they're asking is clearly stated. Although, my next point is kind of like seeming like I'm going to jump the gun. But I somehow don't think if truly the background is kind of like there's like some disagreement in like not having a unified way of categorizing complications post-op in your surgical procedures. I don't think just doing like a cohort study would help in getting a unified classification system. Something more like a systematic review would have been better. I don't know. But your question, yes, I think the question is clearly stated in the introduction.
Yeah, I agree with what you said there. I think especially, I guess we'll get into this more in the method section. I understand what you said there, but like I don't want to talk about it now. We'll save it for the method section. So, does anyone else have anything to add in terms of the introduction and the way that the question is being asked, the way that the background data was presented? Do we think it's sufficient? Does it adequately include things that would help you to justify their question that they're asking?
Yeah, I think the background is okay, because they talk about multiple classifications and they identify like the kind of the failure in each. So that is why they said, okay, let's come up with a novel one that will like take into considerations all the ones that exist. And I think they talked about two authors down. Talk about two authors right down there.
Which one? This one or this one?
No, wait a bit. I think it's Clavian and Dindo. I think we talk about, we base our classification on the proposal of this. So they kind of use this and they modify it based on what has been already published to come with something that's uniform that will help minimize all the drawbacks of the other ones. So I think everything's clear.
Yeah, and if you notice, like these two guys were the ones that proposed the, I guess, really good classification system that's been used in general surgery. Cliven proposed the original one, and Dindo kind of modified this in a way that their hospital system also were using this for 6 years, I believe. Okay. So let's jump into the methods section here. just off the back, I mean, what could you say about this method session that you think is missing, and what could you say is missing, and how do you think things could be better in this method session, without asking any specific questions? I just want to get a general overview of what people think, and anyone can answer this one. Ezekiel, do you have an opinion?
What was the question again?
Just off of the method section, from your reading of the method session, without asking any specific questions, what do you think this method session was limited in, and how do you think you could do it better?
I actually have nothing to say.
Okay, that's fine. Anyone else?
I think for me, like a general overview, they actually said like basically similar stuff on what was found at the abstract section. Yeah, they talk about deviation occurring within 30 days post surgery. I don't know if they actually like consider a particular, literature like to say, okay, let's consider but within 30 days, because I know of surgical site infection where we will classify those infections and usually around 30 days. I don't know what they actually use to do that. And they considered both adverse post events and negative outcomes. Yeah, like let's say in case maybe they operated you were fine, and later on you develop a complication, they'll consider it. At the same time, if they operated you, everything went the wrong way, they will still consider the same. So that's it. And according to that, now they gave now the different grading systems.
Yeah. So I agree with what you said. I think especially like when you first, go into reading the method session, they define what they feel they give a definition for complications. And the best question to ask from this is how did you come about this 30 days of surgery? Like what is there particular references? Is there a particular method that you used to come, to just standardize this 30 days of surgery as deviation from normal postoperative course? And also, I mean, then they went into like explaining the different grading forms and what makes them what, which is okay. But at the end was where I noticed, where they spent the most important part of the paper, where they spent very little time on. They kind of talked about the time in between when the data was collected and how many patients they chose, but they neglected to talk about the inclusion criteria for all these patients. They mentioned that they had demographics available, they had medical records available, they had radiological images available. However, they didn't show any proof of this or even included it as a part of an inclusion criteria in the paper. I feel like that's a major limitations of the method section. I don't know if anyone else agrees.
Yeah, it's same, because what I know is that with the method section, usually we use the PICO criteria. PICO, that is the participants.
Population. Yeah,
the population. Yeah, because as exactly as you said, that section is just too small, because that was the main thing on the paper, but it's just barely few lines. So for the population, they talked about patients who were operated in fact, any patient that was operated in that department, they talk about it. And now for the intervention is any operation. Comparative group is not mentioned there, and I think the outcome that is the outcome that's being used to grade. That is either you have a complication or you have a poor a poor outcome following the surgery. Yeah, I think that is it. Even though that section, as you mentioned, is really, it's not really elaborate.
Yeah. And I also feel that the addition of particularly a table that identifies the patient characteristics, the age of the patients that were chosen, sex of the patients, particular comorbidities that may be present in the patients, and other variables too that could potentially cause, I guess, a bias in this case, in this study too. So
yeah. Okay, so if I understand well, like saying that like there's no proof from like what they are saying here is right, if I understand.
yeah, because I feel like it makes it difficult for you to want to generalize a study because you don't know how they chose their patients, right?
Yeah, actually.
So
You just mentioned, but they don't show. They don't show it actually.
yeah.
Yeah, I completely agree with that as well.
Sorry.
Yeah, I completely agree with that as well.
Yeah.
It's kind of like important because I can't redo this study. If I wanted to carry it out in the center, it's kind of like difficult to redo and then compare results and criteria. I mean, it would be important to have all the patients in your facility for a period of time and then try to, I'm not sure exactly how they work that out. So I agree.
Please, I have a suggestion, I think like not for us not to judge that fast. I think that we can still check on the results section when we reach there to see if actually they give the various features of the different participants of this cohort. I think we'll go to the result section before now. Then we can conclude actually to see if this is really something that we can replicate or not. Yeah,
I agree.
Yeah.
So I just one last question just to ask in the method session. Do we think, based on the presentation of how they chose their patients, do we think the process of subject selection is clear?
I don't know. Is any person or I should go on this?
How about let's see, D George. No. Techno Spark 4. Do you have any thing to contribute? No. How about you, Ezekiel?
Yeah, I didn't get what you had actually. I think.
Yeah. So based off of the way that they presented the methods, do you think the process of the way they selected their subjects, you think that was clear in the method section?
With the way you guys break it, actually, I think for me personally, they left me to assume some things which is not actually right. So I think it could be better up if they had done some necessary things you guys actually raised.
Yes, I agree. I felt like, around here where they say selected cases with neurosurgical and medical complications were analyzed in depth and discussed, but these were actually not, talked about within the method. So this hasn't been shown yet. So let's go into the results section and see how they talk about this or how they present their patients. So,
hello.
Yeah, hello.
Yeah, sorry for drawing back. We've not discussed on the grading system. That is, if you check on the method section, there's what they actually elaborated on.
Yeah, that's true. Yeah, thank you. So, all right. So based off of the grading system, I know, Berger, you mentioned earlier.
Yeah, this table.
With this one, right?
Yeah.
You mentioned earlier, you were talking earlier about the method section in the abstract, and you were talking about this, and you mentioned that you didn't agree with the way that they presented the table. So could you please elaborate on, why you didn't agree with the table presentation?
Okay, I didn't agree. For me, it was fine, but I think we could have make it better. Like when they say they made the grading system just based on the need for treatment, but if when you see the expansion here, they talk about the mortality and actually where the patient will be managed. Because for me, that is what the system based on is. This system is based on three things: the need, like that is the treatment that is can be the need for the treatment and which type of treatment. Secondly, the outcome, that is the outcome of the complication, and the setting where the patient is being managed. So these are the three things they use. So I think that they could have mentioned those three things in the abstract section.
So you're saying like particular like things that they did, or what?
Yeah, like okay, let me just give an example. For grade 1, you see they talk about non-life threatening deviation from normal post-operative course. So when you talk about non-life threatening, so you are talking about mortality here. Talking about mortality here. Like if you come to grade 3, they talk about life threatening, and if you come to grade 4, they talk about death. So you see that it's centered around mortality. So mortality has a important aspect on this grading system. Now, when you come at level of the, okay, after treatment is what they mentioned. When you come now at level of the, come to grade 2, to grade 2, they talk about surgical endoscopic. So here we understand that here is admission in the ward. Now here so here talk about, you see the 2A, 2B anesthesia. Then when we come to grade 3, they talk about ICU. Yeah, so because you see grade 3, they're talking about organ failure. So I think that they could also mention, just as an add, that they also consider those which I mentioned in grading their complications. Yeah.
Yeah, I mean, for the classification of the complications, I particularly felt that the table was I guess sufficient and straightforward enough to put the patients in the particular groups that they belong to. And when they say like the treatment based, I think the table did a good job, really talking about where the patients, each group should go into on this part. So
it's fine. Like for me it's good. I'm just saying like a little that will make it better. Like, you know what I'm saying?
Yeah.
Like even when you see the grading here, you see that the grading is not that uniform, because when you come on grade 1, they mention if it's life-threatening or not, but when you come to grade 2, they don't mention it. They don't mention in grade 2. So I'm assuming that they did a great job here, because I'm sure that there was probably a classification which tried to be uniform, but could not actually, like there were some lacks. So they tried to remove that so as to make everything uniform. So that's my opinion.
Yeah, I think you bring up a great point, in form of uniformity, because assuming, which we'll discuss later, that's something that could potentially go into a limitation section about the fact that although they're trying their best to bring this table that could potentially unify outcome and complication reporting, that it could still not be uniform, and it's not uniform because of how hard it is to really put these patients into different groups. That could potentially go into the limitation section.
Okay.
And then then they presented the second as a table 2 as well. Let's see. Dr. Chibukem, are you here with us? I don't think his microphone is working.
Yeah, they did a great job. Yeah, they give the examples. Huh? Great job.
Yeah, I think this was
Yeah,
a good.
like.
Go ahead.
Yeah, that's really good. Yeah, like that's really great. Like let's say for example, I'm a student. Maybe I want to classify. Sometimes also they will face difficulty with the classification systems, but with these examples, actually it's kind of very easy for us. Like I'll take this example of how to treat surgical sites as there's a clean surgery, clean contaminated, dirty surgery, and actually you have a table that will give the examples. That will guide someone, like, because for sure you cannot include all the complications here, but at least with these examples you can guide you on which one, like where which one will fall. Yeah. So I think they did a great job with this table.
I agree. I think I think the sub compartmentalization of the original table one, because I felt that the surgical complications and medical complications that were mentioned down here, they needed to be explained further, because how do you really classify medical complications from surgical complications? And this really helped to bring a good example to that, so that way you can actually visualize them and be able to see them for yourself. What I didn't understand, however, was how the transient and the persistent suffixes fit into this table. So that was, a limitation that I didn't really fully understand why this was there. So because it didn't go anywhere in this table.
For me, I think, yeah, it's true. It's true. It didn't go, but they were like kind of, for me, I think that they were kind of elaborating the grading system, like to say in case it's more than 30 days, you talk of persistent. In case it's less than 30 days, you talk of transient, even though it goes beyond the upper margin of the number of days they set for the classification. But I think that's what they were meaning there. They mean there.
Thank you.
Yeah.
Okay. So we'll jump into the results section. So I know for the results section, let's see. Is there a better way that you think this data that they presented in the results section, is there a better way that you think it could be presented?
Hello.
Yeah, hello.
Yeah. I think I love the way they presented like the percentage and the number together, like it kind of flew together. However, I would have appreciated if there's kind of a visual representation.
Like in the sense of what?
Like maybe a figure.
A figure or even a table would have I guess helped to make this results section stronger.
Yeah.
Berjo, what do you think?
For me, I think from since the beginning, this article focuses just on the grading system. They don't give much details like this age, because I thought that maybe in the result section they'll give a little bit on demographics, but they didn't mention that. They didn't mention that. So it's that this article, like, they just focus on, like, it's like they went to a center, just took people, and like they kind of, with the people that they had, they kind of came out with a draft of a grading system, and like they took a cohort and see which one will meet the various like the various classification. Like they didn't go much into like giving the demographics, the comorbidities, maybe the sex, or maybe which particular type of procedure? Is it maybe is it an endoscopic surgery, open surgery? Yeah, I think that's it.
Yeah, I feel like I agree with what you just said. I felt like, like before when we were talking about the patient characteristics that could have been a table that was also presented in the method section. I felt like based off of how they chose patients, they could have a table kind of that could help to highlight certain factors that are more statistically significant to cause a patient to land in one group or the other. Perhaps probably doing like a univariate analysis or multivariate analysis or something like that. I felt like that could have made this result section stronger. I think the results was, simply just presented, as is, and just to see, okay, this is what we check all this, we looked at all these patients and this was what we got. But, there's also like no statistically significant aspect of the result that could say, okay, can I really actually translate this into, other population of patients? So
but anyway, I think that they probably mentioned all those limitations at in the limitation section for the study. I'm sure about that.
Yeah. So, is there any other points that that anyone wants to raise about the results section?
Can I give a last point for the result section?
Yes. Yes.
Yeah, it's true. It's true. What we mentioned that was not there, but the results answer, like the result here tie with the method. What did they use? It tie.
Absolutely.
Yeah. It goes with the method they use.
Right. It in a way, it tries to answer the question that they originally tried to pose. And I don't know if this is going to be a widely accepted classification system, but trying to make sure that it fits with their grading system, it absolutely agrees with it. So I agree with that.
Yeah, and for what we talk about the practice, so because usually what I know is that when we are doing when you're reviewing an article like that, usually you want to talk about, is it practically meaningful? Is it statistically significant? So usually those two questions you have to,
Yeah, so that's the problem. Like I said earlier, like you can't see the data doesn't present any statistical significance that can be translatable to, other patients. And it's also, like I said, it's lacking patient characteristics that you can use to say what patient populations can this go into. I mean, it's yeah, it's something that I think it's definitely lacking in this result section. So
yeah.
And we're gonna discuss. We're gonna do the discussion. Just kind of ask some questions. So my first question would be, are the results discussed? Do you feel the results in the discussion session were talked about from multiple angles and placed into context in the discussion section? So I felt like the results in the discussion session, I felt like it, kind of brought in different perspectives from different backgrounds in the literature. I think more importantly, where they discussed the 4 already published articles that are out there proposing similar classifications for I guess putting together complications of patients. And they, in a way, for each study, some of them, they talked about what their limitations are, like in the sense, for example, in the Bonsanto paper, they talked about how the sensitivity of non-surgical complications was lower. However, probably because the events related to ICU data were initially excluded. But then they said the authors only reported complications during hospitalizations, but they didn't have any assessment concerning the severity of each event. That's like each limitation from different papers to come in from multiple angles to help support the data that they presented. And I felt that this table helped to put a mental picture of these different papers and what they were actually about, and what classification methods are they presenting, and how does it fare to the one that these guys are presenting as well. I don't know if anyone have anything to add in terms of this table and its agreement with the results and the discussion section.
Anyway, for the table, I have nothing to say. The where I can say a little bit is at the conclusion section. Yeah, they stated clear that they say this is a simple, practical, and easy to reproduce way to report negative outcome and discuss how it could be applied. So if I take this conclusion, so they just give a simple something which is practical, easy to reproduce, and they see how it could be applied. So that is what they give to us.
Right.
So
and
yes,
go ahead,
yes.
go ahead.
Okay, thank you. So with this, they simply tell you what they did over there. They simply tell you what they, and they say further discussion is expected with
Right.
the hope of reaching consensus. Yeah.
I mean, do you think there's anything that could be changed about the discussion section, or that you could add into it?
For me, I think, okay, the discussion section. For me, I don't think so.
Yeah, I think it's weird that they don't have a limitation section to talk about the limitations of their studies. What do you
yeah,
agree?
but yeah, they did not mention, but from the conclusion, they say that further discussion is expected. Like they are saying that that from what they're saying, like that they hope that they hope of reaching a consensus about complication reporting practices. So it's like they're saying that it's still open. It's still open to a discussion. Like, yeah.
Oh yeah, I mean, yeah, I agree. It's still open to discussion. But in terms of like, their presentation of the data, like what are the limitations in terms of the manuscript and how they, I mean, I could think of some limitations that I felt that the paper was lacking. I mean, that they could have added into the limitation section, such as the fact that this study is a single center study. Say it was a multi-center study, there's a more reliability with generalization of patients at other institutions. I felt that the fact that they didn't add inclusion criteria, certainly a limitation to the study. Maybe they didn't have all the patient characteristics that they thought that it did. So I'm not sure about that too. So, but
yeah. I agree with you completely. I agree with you. I agree.
So yeah, I think this brings to the end the review of this paper. Is there like any last minute questions or potential discussion that anyone wants to start?
Yeah, I think that for me, like all the participants, like, are supposed to, like, because usually when you finish a review, you're supposed to give a general appraisal. Like, do you think that this paper is important? Do you think that it was worth publishing it? So I think at least each person each panelist can give at least an opinion of like the overall view of the paper.
Yeah,
as we have gone through it. Yeah.
So I'll take this first. I think this was a pretty good paper on a not a novel but relevant topic that's presenting an idea that could help to improve patient safety and quality of care and all that stuff. I think did a good job in establishing a simple classification system that certainly can be that could be used at other institutions and stuff. In terms of the data presentation, I felt that they could have done a better job. Certainly including more factors that could help to generalize the study to other populations in other parts of the world. So, yeah. We can start with like Ezekiel. What do you think about the paper?
Yeah, I think overall, like you said, the paper it's actually good, though with some limitation. But sincerely, the authors they did a good job. Did a good job, and I don't know. I would have actually appreciated if the discussion was actually broken into section because it was indeed lengthy. So I think that's just my view. Yeah.
I agree. Okay. How about you, Techno? You want to say something?
Yeah. First of all, I'm really sorry. I really want to apologize for joining late, and I've listened to you all and what I think about the paper. The study cannot really be considered as a study which is reproducible because at the level of the methodology, normally the methodology is the most important section of a paper for a review. But when we read through this one, it's not really clear. We don't understand many things. For example, the 30 days you mentioned above, it's not really clear. And when we go up to the criteria, the inclusion criteria are not really clear. They are not defined. The exclusion criteria too, they are not defined. And it's not only that, the sampling is not clearly defined. And those are a little bit problems which we can face while reproducing the same study. And at the level of the conclusion and discussion and conclusion, as you said, just a minute, as you said above, at the level of the conclusion is always important to highlight the limitations the person conducting the study encountered through the study, but here we cannot really find it. More to that, still at the level of the conclusion, we don't have suggestions for future researchers who will need maybe to carry on the same study, and it's a really bit difficult for us. And even at the level of the results, the best way to present the results is through a table or figures, but I didn't really see it right up because maybe I came late in the previous pages you went through, it was mentioned, but I didn't see it.
Yeah,
So,
I agree with what you said. They definitely didn't have a tabular graphical representation of the results. And that was, one of the things that I thought was a major limitation to the study. I felt like if they add a table or a figure, it would certainly make the results section a lot stronger than it currently is. And they also don't have, any, like I said earlier, univariate or multivariate analysis that kind of help to highlight any factors that could potentially predispose certain patients to being in certain grades, maybe grade 1, 2, or 3, or 4. Is it their age? Is it their comorbidities? Sex? So things like that. So yeah, it makes it hard to generalize the study.
yeah.
Hello.
Yes.
Yeah, I have a little disagreement with the fact that you mentioned that the study could not be reproduced. From my own point of view, is that we cannot generalize the study, but I think you can reproduce it because they gave a grading system. So if you take this grading system and you go to a different center, based on the example they gave, because they give 2 boxes, that is the grading, what they meant by the different gradings and examples. So if you go to a different center, you can just choose patients. Like for what it's true, they were not really concise in their methodology, but I think that you can reproduce it, but like how do I say it? Like there are not enough arguments in the method that will say, okay, let's generalize the study. But for me, I think you can reproduce it. Like if you take a different grading, I go to a different neurosurgical center, you just identify the patients and you can place them in those different grades. Yeah, that's my
Yeah, I
point of
agree.
view.
I agree with what you said, Rizzo. Yeah.
Doc, but the fact is, if the design of the study is not really sound, then you cannot really trust the results, neither the conclusion or the discussions. That's why I'm saying I don't think the study can easily be reproducible. But you're also right, because by looking at the grading system in that way, but yes, you can do something, but not the same study. But
Yeah.
that's my point.
So I mean, I think understanding the dichotomy between the generalizability and reproducibility, in the sense that, yeah, we could definitely do the study again, might not get the same results, but they gave enough instructions to be able to, do the study and still put patients in different classifications based off of the surgical complications, medical complications that they presented here. However, because one, this is a single institution study, they don't have any patient characteristics that they presented. They don't have any inclusion or exclusion criteria. It would make it particularly hard to generalize this to, say, an hospital in Senegal versus an hospital in Nigeria or a hospital in the US. So I don't know if that makes sense. Yeah. Ezekiel, do you have anything to add?
No, that's all for me actually. I think if no one Mike, are you done?
Yeah, this is pretty much the end of it. We were just kind of given like last minute thoughts.
Okay.
So
Yeah, thank you very much. Like it was really an wholesome session. Personally, I think I learned a lot. I learned a lot, and I saw another perspective. I saw more perspective of how to tackle papers while reviewing them, how to criticize paper positively, like positive critics. And I believe it was, and Bejo actually made it more interactive, and yeah, and many of us,
thank you so
I
much,
know,
Pedro.
Yeah,
yeah,
it's my pleasure.
and
It's,
many of us, we
we
actually,
learn. Yeah.
Yeah, initially, oh, sorry, Techno, you get.
it was indeed an amazing session. Like, okay, go ahead, Techno.
Thank you very much to you all for the meeting, and I just wanted to highlight another thing is concerning a paper. It's not only the reproducibility of the paper which counts, even the validity of the paper and the reliability. By validity, I just mean to measure what you intended to measure, and with the reliability is the ability to measure consistently. So we couldn't really see it in this study, but anyway, it was just a session to learn a bit more about how to criticize the study, and I would like to thank you all. Thank you very much for all. I learned a lot from you too. Thank you very much.
Yeah, absolutely.
Hello.
Appreciate it.
Hello.
Yes.
Hi.
Please, Techno, please. Sorry, but your name, please. Can I know your name, please?
My name is Tangmi Dabo Eric Adrian. I live in Congo Republic, Democratic Republic of Congo.
Okay.
I'm actually here, but I'm a Cameroonian of nationality.
Okay. Thank you.
Yeah.
I have a document here. Just that I have difficulty sharing it. I don't know. I'll share it in the AFAN group once we're done the meeting. It's actually a review template, like on the different, like the steps in reviewing a paper from Plus Academy. Yeah, I'll share it in the group so that if possible, if you guys see that it's good, then subsequent journal clubs will use it to actually like go through a paper.
Okay.
In order.
Cool.
All right, thank you, Pedro. I'll be ending the meeting now. Then Michael, I really appreciate it. Was really an amazing session. And as you can see, most of us said we learned a lot and we learned a lot. Thank you so much. Thank you everyone for coming. Thank you so much.
Thank you.
At this point, I would love to
thank you.
end the meeting now. Thank you. Do have a wonderful weekend.
Yeah, same to you.
You too.
Same to you.